time for people to dial in. I'm a director at the California Healthcare Foundation, and I'm delighted to welcome you to the California Improvement Network. This is the second of 3 webinars that we're hosting on how different organizations, plans, clinics, and residencies are managing the opioid epidemic and how they're working together to support cultures of safe prescribing, both to decrease future addictions and future people dependent on medications, as well as to safely and compassionately treat the people who've already become dependent on opioids. The California Healthcare Foundation is trying to do work in this area, and if you're interested in what we're doing, feel free to go to our website at chcf.org, and you can see information about the webinars, about our new program supporting residencies in safe prescribing. We've started a residency action group and some papers we've written on the topics. I'm really delighted to welcome you. We've got 2 great speakers, and I want to go first to a couple of housekeeping items. First, the session is recorded, so if you know anybody who would be interested, that recording and the slides will be available on our website within a week. We do anticipate a pretty large group, so we're using the chat function for questions. If you have logistical issues about the webinar specifically, please just post to the host. But if you have questions for the speakers all the way throughout, please use the chat function and chat to all, and that way others can see what questions you've had. We're going to be having 20 minutes for each speaker, and then we'll have open Q&A for the last piece of the webinar. The webinar formally closes at 1:30, but we'll keep the lines open between 1:30 and 2 if you would have interest in staying on and asking some additional questions of our speakers. And we are very interested in your feedback, so do take a moment at the end of the webinar to answer a couple of brief questions. I'm now going to introduce our speakers. I'm really excited to have 2 people I think we're going to learn a lot from today. Both presenters have very interesting stories to tell. Both Dr. Shah and Dr. Moore have deep histories in the safety net. Dr. Robert Moore was a medical director of Community Clinic Olay in Napa for 18 years and was also a respected leader in quality improvement in the 4-county clinics in that area. And now he's been Chief Medical Officer at Partnership Health Plan for the last 4 years. This plan has 500,000 members in 14 Northern California counties, and he'll be going through the initiative that he's led in the last year, focusing on safe prescribing from both a community approach and a health plan approach. His approach was very much informed by Dr. Amit Shah's work in Portland. Many of us in California have learned from the work that he did when he was medical director of a multi-clinic county system, the Multnomah County Health Department. In that role, he led a citywide effort to improve safe prescribing practices. And then when he took a senior medical director role at Care Oregon, which is a statewide Medicaid plan that's now taken some innovative approaches in their health care reform efforts, he's then been taking the plan approach to try to deal with the epidemic. So you're going to hear 2 plans, 2 approaches, and very much embedded in a community effort. So we'll first start hearing from Dr. Amit Shah, if you want to take over from here.
Thanks, and welcome to all. And I'll get into this knowing that we would probably hopefully have some room for questions as we go there. So I wanted to start off with just sort of some 2 case studies and some learnings from these. And the objectives would be to be able to review a large clinic system approach, when I was medical director at Multnomah County Health Department, and it was less about the clinic system approach as much as it was a community approach that happened off of that work. And then really review how that synergized with the work that I'm doing with a planned system approach and some learnings that are involved with that. So I think we all know about this public health epidemic, and this was sort of what I was confronted with when I was at Multnomah County Health Department. The overall rate of poisoning grew 360%, death from prescription opiates, patients with prescriptions and people who obtained the community pill, which means they weren't receiving a prescription per se, but they were somehow getting access to these pills from people who were receiving a prescription for opiates. And we knew that the prescription written to death ratio was high. So all prescribers had at least one a death related to opiates. And it was quite remarkable to look at that statistic and be able to see that from a public health approach that really, sort of created the impetus for people to say, we've got to do something about this. And then the part that shocked people the most is we saw the fastest growing trend, which is continuing here in Oregon today, of 15 to 17-year-olds on prescription opiates. And, you know, when we look at the data, and it's quite obvious, it's not as if people are prescribing, providers are prescribing 15 to 7-year-olds prescription opiates. We know they're coming from other prescriptions in this community pill notion. We know the impact of the chronic opiate use that happened, you know, just enough Vicodin circulating for every adult to take, you know, a 500 tab every 4 hours for 6 weeks. I mean, that's kind of extraordinary when you think about that. And then all the side effects that are related, hyperalgesia, hyposexual function, dependence, diversion, misuse, abuse, the respiratory issues, and then really just the striking notion of the deaths that are created that surpass car crashes and homicides. And then in our community, you know, methadone being, you know, the most common source of overdose that's in there. And the striking part is that death, being so significant, yet so little strategies or approaches taken by community / plans and systems to do something about it. That was a very striking learning that, you know, I've really reflected on about how do we really do something about, you know, mitigating death, obviously. So the bottom line, and it's been the messaging that we've been really doing here in the community and both in the clinic system as well as on the plan level is, you know, if you prescribe, you're responsible. And that responsibility doesn't mean that, you know, you're alone in this, but you have responsibility in this. You know, no other med has this high risk profile and so little monitoring. Every prescriber's got to use caution based on evidence and standards of care, and it's no longer acceptable to prescribe as you see fit. And I think that's a really important message that we started doing, you know, with the work that I did at Multnomah County, but then also subsequently in the plan work of really saying that it's just not acceptable to practice this way. And then for us, you know, the Oregon Medical Board findings, you know, which was surprising to most providers, was that the #1 opiate prescribing is people over-prescribing and or inappropriate prescribing, as opposed to, you know, historically people were always worried that they were going to be dinged or monitored or get in trouble for under-prescribing when the notion of pain as the 5th vital sign really came forward. So at Multnomah County, there was about 3,000 at the time. There was about 3,000 patients on chronic opiates, alarming increase in opiate-related deaths, and reports from patients on opiate misuse. I mean, real clear on that. And the approach was, how do we create safe and appropriate opiate prescribing, develop alternatives for treating pain, strengthening ties with addiction treatment, and collaborating with other healthcare delivery partners to create a new community norm and to stimulate a community approach for larger issues of chronic pain and addiction. Recognizing this happened years ago, right? Not that long ago, but long enough. And you'll see as I finish the presentation, that last part of stimulating a community approach to larger issues is finally happening now. You know, so 4 years, 5 years after that effort, we finally are getting to that point there. So it's not like it's easy work and you snap your fingers and it's done. It's just a series of steps that had to happen to get there. So real specifically, the key changes were, you know, we created all these policies, we created all these things. I wrote an opiate guideline policy, I did everything, and we just couldn't change the trajectory in the clinic system. And so what wound up happening was, through a series of reviewing many charts, over 1,000 patients who were on chronic opiate prescriptions and looking at the reasons why they were on it, we were able to identify contraindications to prescribe. And then all I did was I simply just clearly outlined those and then said in front of the provider group, being their medical director, saying, you know, from this day forward, you can't prescribe if these contraindications exist. And if there's an exception to that, you need to have an internal group we created, an opiate oversight committee, review it. And all new patients were screened and reviewed by this committee. And the contraindications I list here are, you know, for you guys to look at, and, you know, and the point of it is less about the specificity of these contraindications and the evidence that surrounds them, and more about the fact of really bringing to light that there are circumstances where it is contraindicated to prescribe, And, there's got to be some adherence around that. And when we did that with our guidelines, it really changed the practice. They had the same guideline that I wrote, but when we added the contraindications at the top, all of a sudden the guideline was being followed. And that made a significant difference in the decrease in the use of the meds. We created a ceiling dose that should not exceed 120 MEDs, morphine equivalents per day, and all patients being prescribed more than that had to be referred to this committee to give other technical expertise and consultation and decision-making whether that was appropriate to continue or a taper would be needed. And then Oregon was moving more consistent to a consistent standard developed by Washington State, so a very similar approach that they did, but it was done much more organically in Oregon. So that kind of transitions to this plan opportunities. And, health plans have a unique opportunity to understand the risk and utilization from a population perspective versus individual perspective. What do I mean by that? We were able to take the data of all the patients that were being prescribed opiates chronically, and we could see that they were touching the ER. We did a massive exercise around high utilization through a federal grant that we had. And when we saw the patients that were high utilizing and creating huge costs and burden for the system for a variety of reasons, and when we did a root cause analysis, we found that a large percentage, if not the majority of them, opiates was a driver for all of that. And so it was important to share that from a population perspective as opposed to the individual experience that, providers and their teams may be having on the patients. And then doing interventions that support delivery system initiatives. So how do you align the plan activities that are needed to support the delivery system? So I'll give you a very specific example. In Oregon, we have the Oregon Health Plan, which defines the benefit that the patients can get, that's really clearly above the line, below the line benefits. And one of the things that's below the line is the use of PT in chronic pain. But what we did from a plan perspective to support the delivery system initiative is we recognized that people were aggressively trying to take patients off of opiates and had very few modalities to manage the patient beyond medication. So we, as a plan, took care of that rule, and we authorized and allowed that benefit to exist for something that was below the line. So that was a plan initiative to support the delivery system in doing that work by offering physical therapy services if it was deemed necessary and needed to help them taper off the medications and manage their chronic pain. So the Care Oregon interventions specifically was the development of non-medication pain clinics, behavioral health-based, and a coordinated care organization intervention. And in Oregon, the healthcare has been transformed into CCOs, which are just basically a way to combine physical, mental, and dental health in regional areas to be able to design the clinical strategy and to carry the risk for the population, the financial risk for the population. So through one of the CCOs that Care Oregon's involved with, we approached the community and asked them what they needed to be able to optimize their delivery initiative. And they said they didn't have the capacity to have a non-medication pain clinic, not a medically interventional pain clinic, a non-medication pain clinic to give peer support, non-medication therapies like acupuncture and et cetera, to be able to have cognitive behavioral therapy if needed, to be able to go through a way to sort through if people have true addiction issues. And so we were able to fund and pilot a program in one of our coastal areas of Oregon to put this clinic in place by providing the monies for it. And that clinic to date, the data has been extraordinary. The patients that have engaged in it have successfully tapered their medications to a level that's safe or have gotten off the medications while seeing PHQ scores decrease as well as their perception of their function increasing. And then really providing a lot of pharmacy analytics that showed high dose totals, dangerous medication combinations, dangerous medications from multiple providers, a list of who was on methadone, and really who are the folks that you would do a pharmacy lockdown on. And this is a graphic that just really quickly that we produced that gives a sense of like the percentage of members utilizing the opiates And then for example, the CCO in particular, where their averages and the percentage of opiate members utilizing opiates. And so what it's really just trying to show you is how many patients you have and how many of those patients are utilizing these opiates chronically, and what would that look like in your community. And sharing that graphic with all of our partners. Obviously, I haven't listed names on here, but we finally got to the point where it was blinded like it is right now, where we got to the point where we actually unblinded it. And that was pretty moving for all the partners to see that and see where they are, compared and contrasted to each other. So quickly to Jackson Care Connect, which is another coordinated care organization that Care Oregon owns in Southern Oregon. They had significant opiate overuse, and the community created a forum to address, started by their public health department, and really focused on education, awareness, and development of guidelines and recommendations, the Southern Oregon Opiate Prescribers Group. And the provider community responded really clearly, not the plan, that said, we want you to enforce a 120 MED limit. So what happened was, as a plan, we created an authorization process where providers and patients were sent a letter if the patient was on 120 MEDs or higher, and the providers needed to submit a taper plan. What we did differently is we didn't say, oh yeah, if you're over 120, we're just going to cut you off. We submitted a letter saying, 120 and higher has safety risk profile issues, blah, 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 all these different factors in there. And in order to help you with this, we need you to submit a taper plan by, 90 days from now, and included in there what help you need to be able to do this, or what exceptions are you asking for. This patient needs to be on this for the following reason. And if there was no plan in 60, and it kind of, quite honestly, got fudged to 90 days, the medication refill was denied. And the provider requests for exceptions were reviewed by a team that we created that was multidisciplinary, and patients could certainly formally appeal if needed. And what we noticed was we had a huge decrease in the number of patients that are on greater than 120 MED, lots of community provider angst, right? It's one thing to say, oh yeah, I'm totally on board, and you better make sure that you enforce a 120 MED for me, which was what was asked, to, wait a second, you're going to stop the meds, or you're going to not do it because I didn't do a taper plan? I mean, there was a lot of angst around it when the devil in the details started happening. And it required lots of direct support, technical assistance. So from the CCO plan perspective, we created a team of a medical director, which at the time was me, a nurse care manager, a pharmacist, a clinical pharmacist that we have, and the key was we found this superstar behaviorist in the community who joined our team. And that behaviorist, did a lot of work with the clinics to help the patients and the providers really move down this trajectory of trying to, support what was needed behaviorally to move some cases that were really difficult. But I put in there is that she also played a big role in helping the providers out. She did a lot of support for the providers around it's okay, you can do this, and dealing with all the issues that providers have when embarking on this. So real quickly, so what? So I showed you like a little bit of Multnomah County and the work that was done there about creating guidelines and really enforcing, contraindications and creating a forum to be able to have that discussion. Showed you what happened in a place where the community wanted a non-medication management system. Showed you the kind of analytics that a health plan can provide along with the resourcing that's needed from financial, but also in Jackson Care Connect to really enforce a plan PA type of benefit restriction around 120 MED. And what we've seen is our deaths really peaked in 2012 and have slightly decreased since. Jackson County, the community is finally moving towards the center. The ripping the Band-Aid off with this 120 thing created so much angst and drama and issues. I mean, you can't even believe how many phone calls and emails and stuff that I would get from providers and community members and patients and everything. But it's finally forced a lot of ways the issue around the technical assistance that's really needed and the community moving towards the standard that they agreed on, but actually operationalizing it. And then it started moving these programs that are needed to develop supporting the population, using things like the CCOs, the Coordinated Care Organizations, and the health plans to really help direct the resources and knowing where to direct the resources to help support the work the delivery system's trying to do. Multnomah County saw a dramatic decrease, 40% decrease in the number of patients on opiates. And I like to say this, and this was at the time I was there, we still had an 80% patient retention rate. And I think that's critical. Doing this work is really difficult, and it's important to study what happens to the patients when you're doing this. And our goal was to have them stay with us, not leave. Heroin deaths in the Portland area are greater than prescription opiates. They peaked in 2011 and have had a steady reduction, but the prescription-related deaths have fluctuated without necessarily a downward trend, and I think that's that wave we're seeing, especially with the 15 and 17-year-olds. But, these efforts are going to come to fruition like we've seen in other communities. So the local work led to an Oregon-wide approach. So the local work at Multnomah County, the local work on the coast that I described in Jackson, and all these areas that were going on created this effort to create a community standard in Oregon around what can we all agree to. And it's created finally, as of last month, the comprehensive payer approach, because all this work was within Medicaid, but now it's broadening to the commercial insurance payers and plans, and we have a group together that's forming to be able to do that. And it's really been sponsored by all the health plans. And then really, ultimately, it's strengthening primary care. I have always said that chronic pain is a chronic disease, and that chronic diseases are best managed in primary care and the teams that support primary care and the patient to do this work. And so really understanding from a plan perspective, what is the support and technical assistance the clinics need to do this work? And if you identify those, I've given some examples, you can apply the resources related to any of that. So I'll stop there and hand it over to Dr. Moore, and then certainly we'll entertain questions as the presentation continues and at the end. Thank you.
And thank you so much. It was a great presentation. Feel free to use the chat function to start teeing up questions now, because I know a lot of people have a lot to ask. One thing I want to call out with both of our presenters is that how much of an emphasis has been on primary care. Even though many counties, the first thing they do is work on emergency department guidelines, it's a small piece of the problem, and therefore primary care is a big piece of the solution as well. Okay, Dr. Moore.
Great, thank you, Kelly, and thank you, Amit. As Kelly mentioned in my introduction, I'm a family physician and have worked in a community health center for many years, and I cared for patients in that setting with chronic pain and had my own panel of patients on high doses of opioids in the days when we thought differently about using opioids, and even had a couple of my patients die. And more recently, when I joined Partnership, I found that some of my young interns, or we'd have student rotating through, they had friends of theirs actually die of opioid overdoses, not for people on chronic pain, but folks who were taking it for other reasons or mixing it with other drugs. So it's one of the things I became aware of is how much it touches people, just as Emmett said. And so when I came to the health plan, it was a good opportunity to sort of think about what I could do at a larger level. Let me just briefly tell you again the target audience for these presentations is sort of what can health plans do. So in my mind, I'm thinking about what can my colleagues at other health plans around the state, what lessons can they learn? So it's good to know what setting I'm in. Partnership Health Plan is a Medi-Cal managed care plan and we have a county organized health system model, so we're the only managed care plan for the 14 counties that we're in. We have about 532,000 members now in those 14 counties. And we're not-for-profit, governed by a commission that's represented by the counties that we serve. And a key part of this is our mission, which is to help our members and the communities we serve be healthy, because this initiative is both an opportunity to help our members who have a variety of issues related to use of opioids or chronic pain, but also the larger community, because this does overflow into that area. So even though only about 25% of the population of those 14 counties are members, this does have an impact on the greater community as well. that was our motivation. And I'm going to start the opposite. I thought instead of starting with all the things we did, I'm going to talk about what successes we've had and then what were the keys, and then we'll go through the details, because I think that helps sort of give strength to the details of what we implemented. We've been working on this little by little in different ways over the years. Really took off in early 2014, but we have some data, and what we found is from January to December 2014, when we really focused on this in earnest, we found a 32% reduction in the use of long-acting opioids, 14% reduction in overall opioid use, and a savings of about $250,000 per month just on medications, not on any of the other factors that Dr. Shah mentioned in terms of, emergency room utilization and so on. And in terms of health outcomes, it's hard to get, it takes a while for public health data to come through and be validated. And as Dr. Shah mentioned in looking at the data, there's ups and downs. But given all those caveats, 2 of our counties that had a large amount of overdose deaths to begin with did note, after many years of increase, pretty substantial decreases in 2014 compared to 2013. And so that's a hint. We need to dive into that in more detail to see what is it attributed to, but it really is associated with this big push that we had at that time. So what were the keys to success? And I want to, where does this come from? Chip and Dan Heath wrote a book called Switch: How to Make things change when change is hard. And they have general principles which they talk about, which is that making change for human beings is a lot like being a tiny rider on a massive elephant. The rider might think he's in charge, but the elephant's will always wins. So that both are imperfect. The rider overthinks and overanalyzes, and the elephant acts on passion and emotion. So the Heath's advice is 3-pronged: direct the rider, motivate the elephant, and shape the path. And so using that framework, it's a great book, I recommend it. Here's how we tried to do those 3 things. The first is communicate a compelling need, and I think that I put down the various key messages that we did when we went out on the road to give that compelling need, and Dr. Shah mentioned several of them. The talk about the rising overdose deaths, the increased drug abuse from diversion, the fact that chronic opioids make chronic pain worse, not better, that there's a 3-fold increase of neonatal abstinence syndrome in the last decade, and that PCP visits for taking care of patients on these long-term opioids are actually crowding out the care of other patients, exacerbating PCP access issues, and then decreasing the job satisfaction of many primary care. So those are the major compelling arguments that we thought worked well for our either providers or our communities. Then it's important to paint a picture of success. And if no one's ever done it before, it's harder to do that. It is a lot easier to be able to point to someone else that's had some success, so that individuals and groups can feel like, well, if they did it, we should be able to do it too. And so in this case, we did actually use the case study of Multnomah County to show that with a relatively focused intervention over a short period of time, that there could be some success in attacking this issue. And then communicating the path to success, and that's done by disseminating best practices that are customized to the audience. The best practices vary. And then 2 other key factors. One is the leadership commitment of energy and resources. And this, from the health plan perspective, my job as medical director was to make sure that all the leadership team and the various other parts of the health plan were all in on working on this, because this effort, as you'll see in a couple slides, involves multiple areas of a health plan. And then adding some aligned incentives is helpful too. So in our Pay for Performance program, we added some incentives that help kind of come up with some extra money to align with this. So those were the big keys to success. So now I'm going to sort of go into it in more detail. And the first thing is where did our emphasis sort of increase in this past year. And in March of 2014 is when we officially named Managing Pain Safely as the initiative, which was a group of projects collectively worked together to focus on one problem, which is to manage pain safely. And you can see the goal that we came up with: to optimize the use of medication and other modalities so that pain is treated appropriately depending on the needs of the patient, informed by current medical science. So it was not you reduce opioids. It was really focused on a more patient-centered goal. The framework that we developed to tackle the problem included a steering committee and 5 work groups within the health plan. And in the next slide, there it is. The next slide is a very brief view of that sort of structure. On the left side, you can see in the blue are the steering committee groups. I'm going to talk about them in more detail, but these are the major groups that we had work groups: pharmacy, provider network, care coordination, member services, utilization management, policy, regulation, communication, and community support. So we had these task force within the health plan with the steering committee working on this. Interfacing with the community work groups, we really tried to get every county to get their own community work group going. And that was again built on some of the work from Multnomah County and some of the early counties that were working on this in our county. And you can see the various community work group components, people that would be involved in it. Not every community work group had every one of these on the group, but these are important folks to consider when you're forming your community work groups. In particular, some of them involve law enforcement and legislative officials, others didn't. I think most of the time the public health officer is involved in community groups, and pharmacists are a little tougher to engage sometimes, so that was always a challenge. And then generally the PCPs and specialty, the medical community is the most consistent part of that. And then interfacing these two was our regional medical directors and some administrative leaders in our group, and we've developed some website toolkits and resources to help make that link as well. The 5 work groups, to just briefly, what did they work on? The pharmacy work group worked on what we call formulary enhancements, and it's really changes in the TAR processing to help prevent inappropriate escalations. We'll talk more about that in a second, and to identify medications to help support tapering. We'll go through more detail. The provider work group, we did a survey, we developed the provider work group, and then we developed educational opportunities for them. The care coordination member services focused more on the members, and the key thing here was to make sure that our message was in sync with the members as what we were telling our providers. So what we found when we first started is that our care coordination and and grievances and some member services, they were acting as advocates for the patient. So when a patient called and complained that their provider wasn't giving them the pain medication they've always been on, we would have our member services folks would be sympathetic and say, oh, that's terrible. You know, we'll try to find you a provider that will take care of your needs. And that's not the right message to give if we're trying to tackle this as a community. So they developed alternative scripts and supportive ways of talking to those patients so that we were in sync with the provider messages. For community support, that was really to focus on the community initiatives. And then lastly, we wanted to back this up with talking to the government representatives, so when people called and complained to their legislator, that the government representatives were already acquainted with what the effort was, and also so that they would not, again, say things that were make it more challenging for us down the road. The key 5 interventions, so we'll go through these, are education, health plan, pharmacy, prior authorization changes, additional options for treating pain, community activation, and aligned incentives. So I'm going to go through that in some briefly, but in some detail. So for education, these are the groups that we sought to educate, as I mentioned earlier, the different types of prescribers, other members of the community, all of our internal folks, including our board, leadership team, and staff, the members, and we had a group that we called the OUCH team. It stands for Outreach and Understanding Can Help. That's our internal member-focused teams that focused on how to communicate with members about issues related to opioid use and pain. And that was a very helpful best practice. Also some public education component, and then of course talking to our community representatives. So those are who we focused on, and here were the 2 key messages. The next slide, make this little button work. There we go. The first one was to really communicate there are 3 different big categories of opioid use, and to think about these groups differently. The first is individuals who are just starting on opioids. And the big risk here is that individuals who start on opioids and continue them for more than 3 months have a very large chance of never getting off of those opioids. So we wanted to really coach the providers to be very judicious in their use of short-term opioids, to make sure that they are used for that short-term duration and tapered off before the patient becomes, before they become physiologically changed as a result of being on the opioids. The second group was escalating dosages, and this is a common issue. We actually had a tough time putting our arms around it. We've since developed some programming to kind of follow this. But at a baseline, just to give you some idea, we looked at all the patients who were on high dose, over 120 milligrams morphine equivalent dose a day or higher, and we found that 25% of them in a 3-month period was, or 6-month period, was escalating, and only 2.5% were de-escalating. So that we realized that was a low-hanging fruit. Most of the time, there's almost no indication for escalation unless somebody has, you know, they're in palliative care, end of life, or active cancer, or a couple other reasons. Really, they should be on stable doses, and other modalities should be used for breakthrough pain. So that was an important piece. And then the hardest group is that continuing high-dose pain medication, and Dr. Shah talked a bit about that. The second big message was, of course, to focus on changing the understanding of how to use opioids. The former understanding was there's no maximum dose. You can always go higher. There's really hardly anybody gets addicted. And then now we really need to talk about how the chronic use of opioids leads to hyperalgesia and decreased functioning, because that key message was critical for our staff to understand. Otherwise, it felt like we were just doing this to save money, and we really wanted to talk about how we really wanted to increase the functioning as well as the safety of the community. That was a key message to get across. So what was some of the ways we did provider education? We have a blog that we use to do various postings. We have an email dissemination that we send out to our medical directors of the larger groups. We did some in-person CME events. We have webinars. We recorded videos of trainings. We put stuff in our provider newsletter. We did in-person regional meetings. We co-sponsored Project ECHO, which stands for Extension for Community Health Outcomes, with California Healthcare Foundation, UC Davis, and really got a lot of our providers to use that. It's a method of training providers to have increased skills to provide specialty level treatments, and that in this case it was focused on chronic pain. There's a program called Safe Use Now, which is focusing on customized provider risk profiles and advice, put together by a company called Principal Strategies Incorporated, and then we put a big toolkit on the web. So that's some of the things, and the idea here is to get across is it's not one intervention. You can't just put on one CME and put out a couple newsletters and hope it happened. It's a sustained campaign. It's a marketing campaign. In terms of the next category, the pharmacy changes, we followed a very similar path to what Care Oregon did. But the first thing, though, we did was we really had to get everyone on the same page. So we started with internal alignment, training, getting our pharmacists, technicians, medical directors, and our P&T committee all together, and we did a comprehensive review of the literature and came up with consensus of the best practices. So I think getting everyone on the same page is critical. And then we came up with a 3-step approach that we've done this is over the course of about 2 years on how to use the prior authorization process to help with this issue. And the first step was to scrutinize justification for high doses of expensive opioids. So that's OxyContin, that's Opana, those type of medications. And we really made sure that those patients were being evaluated for appropriate use. The next step, and as a result of that, we had a lot of people on low-cost, generic long-term opioids. So we weren't helping the overall opioid problem, we were just saving money. So step 2, and this was the first time that we did this as a health plan, we made a prior authorization change motivated mainly by patient safety as opposed to cost. So we took the generic medications and we started looking for folks already on high doses and basically really scrutinizing escalation. When we realized that 2.5% of patients were escalating in a 6-month period, we realized we have to sort of turn off that faucet if we're trying to quit filling the swimming pool. So we asked for request of justification, and we would pre-authorize a stable dose. So that the idea is that if they asked for a higher dose, we'd authorize the stable dose so that they could go ahead and get that stable dose filled without any barriers to the patient. But then the escalation required prior authorization. And we only escalated with acceptable medical justification, and we did peer-to-peer conversations wherever possible. This helped really the percentage dropped dramatically. We don't have final numbers, but it's definitely less than 2% of all patients on high doses are escalating at this point. So that was a big win in terms of stemming the tide of ever-increasing dosage. The last step, step 3, is focusing, just as Dr. Shah did, we focused on patients who are on stable doses of high-dose opioids, over 120 morphine equivalents a day. Similar principle as care organ use. We asked for an explanation and basically said, you know, if you have a good reason for them to stay in that dose, let us know. And we encourage the formation of what we call pain medication oversight committees, a variation on the opioid oversight committee. We encourage them to form them locally, and we have one at the health plan level as a backup. And we're tracking the responses to what the reasons that they're on high doses in a PHC level registry, so we can kind of track that over time. So that's the formulary changes. The other interventions, additional options for treating pain, we expanded benefits. We added podiatry, chiropractor, and acupuncture benefit focused on this population. Made some formulary changes. We made duloxetine formulary. We also covered some additional, a lot of other adjunctive non-opioid treatments are covered. And then really we worked in several ways to smooth access to the supportive behavioral health treatment. And one of the best methods, mindfulness and relaxation, is probably the best evidence-based method to actually help folks on high doses get to change the way their brain is wired to a new place. We put a relaxation tape on our audio file on our website, and then talk to our various behavioral health consultants on how to work with patients. Next group of interventions is the community activation. At this point, 8 of our 14 counties have active county coalitions. Their goals are to disseminate standards, nurture a sense of urgency at the local level, develop a shared commitment to making improvement with mutual accountability, and to ensure that everyone's working together towards a common purpose instead of working at odds for each other. Particularly, we didn't want the ERs and the primary cares working at odds. Also, the law enforcement is another good partner in that. Essential elements to success. Since we've had 8 counties doing this, we've learned what is the key to having it happen. The first is a convening organization, an organization that's willing to say, we are the ones willing to take responsibility for bringing the group together, organizing the meetings, taking minutes, calling people, and then a local leader, at least one person who's saying, I'm willing to be the person that is the leader of this effort. If you have those 2 elements, there is a ton, we found there's a lot of latent interest in this topic, and people will come together if you have those 2 things. Lastly, aligned incentives. There's intrinsic incentives. One thing we like to tell people if they complain about why are you doing this, we say this will help you stay on the right side of the medical board in the Department of Justice, so people don't come in and shut down your practice or put you in jail. And then also there's a side benefit, which is that if you have patients who have high doses of opioids and you get them off, you suddenly create a whole bunch of extra appointment access slots for other primary care patients, as we talked. The flip side of that, of the problem with them taking so much time. We've also put some supplementary financial incentives. We have several pay-for-performance programs that we've aligned with this, a pharmacy pay-for-performance, 340B pay-for-performance, and primary care pay-for-performance, all that have elements that are aligned with this. So that way we're all working together. So what we're planning for for the rest of this year is to fully implement that Safe Use Now program, where the prescribers get their own data and safety risk profile. And then others include really rolling out these local pain management safety oversight committees. These are actually happening right now. They're forming, and that's getting going. Really excited about that. Developing a mechanism for categorizing patients for targeted treatment. That's something that Oregon did as well. Piloting support for multidisciplinary teams to support opioid tapering. This is a big challenge. Dr. Shah talked about what they did in Oregon. We're really excited to try to work towards this, and California Healthcare Foundation is helping to kind of help think this through a bit, which we really appreciate. Targeted intervention for patients on newly prescribed opioids. This is exciting. This you can't do with the prior authorization. You have to do this by a reporting and outreach method. So we find people that have never been on opioids. They've suddenly been started. If we can detect that and give input and feedback, maybe we can stop them from being chronic users. So we're going to try that out. We're hoping to pilot the provision of e-consult services for complex patients. continuing offering educational opportunities. And then a big area is there's addiction screening and treatment is unfortunately it's not as well integrated in California as it is in Oregon. So really trying to think about that piece over this next 6-month period. And then finally, educating other groups that we haven't focused on as much so far, really getting into that emergency department, the pharmacies, and then hospitalists as well. So our long-term goals, what have others achieved? You've heard a bit about Multnomah County. Kaiser in Southern California had a 91% decrease in high-dose opioids for non-cancer, non-terminal pain over 3 years. So, but that means that what we've done, we hope there's still a lot more room for further improvement. And what we're really looking for as well is seeing if we can document a reduction in neonatal abstinence syndrome and a decrease in drug diversion. So we're hoping to be able to document that. We're working hard to try to get some data to support that. And that's what we've done in partnership.
Well, great, Bob, thank you so much. It was so valuable, especially the level of detail I think is very helpful for all the plans on the call. We have some specific questions that were teed up, and the first one I'm going to ask is for Amit first and then Bob. When you targeted high-dose members, were you focusing on people who would hit the 120 milligram morphine equivalent across all their prescribers, so they might be getting drugs from several, or were you specifically targeting the people getting their 120 or more from just one prescriber?
Yeah, so that's a really great question because what we did was we started with the folks that were receiving the chronic opiate from, one prescriber. But then what that morphed into was we just said, you know what, we're just going to take the total MED that they're receiving, which included often multiple prescribers. And that in and of itself was an intervention because the primary care provider, for example, didn't even realize that was happening, like they were getting that volume of med. So they would write in on the taper or the PA, they'd be like, why do I even have to do a PA? This patient's getting 60 milligram equivalents, because they didn't know they were actually getting 200 milligram equivalents. So it was kind of an evolution of that.
Bob, how about for you?
So, well, that's a good question. We did about a few months ago pull the report and did our best to pull together the total morphine equivalents and then send that list out to all of the prescribers for folks on 120 or greater. And we found that it's a challenge. Our data there were some, how well linked are the patients to who we thought their primary care provider was. Sometimes there were patients who had not been seen in a long time, so somebody else was prescribing it and they didn't know they were getting it, or they'd never met the patient before, or they had already been, tapered a bit because the data is based on historical data as well. But on the whole, I think most folks appreciated getting that data and were able to use that to start to tackle their population of patients.
One other thing that I wanted to add was that that's related to this that we have done a lot and learned a lot about is we produce that data on the plan side, and then when we have that in partnership with the clinics, what we do often is the clinics then, we help them, because we have some expertise on EMR as well, show them how they could run a report from their EMR as well, right? So they can see that view, and then we do a lot of combination of both our data and their data to get a picture of what their panel really looks like.
That's a really good point.
Go ahead.
I was just going to say it's nice to have that because in most cases, even in health centers, they do have a large non-Medi-Cal population. It's nice for them to put that whole population together, particularly in California, in our counties, the dual eligible. It's Medicare Part D that's paying for those drugs, so we have no knowledge of them.
Great, and I just want to say one thing for those who are not aware, that CURES is our database in California for all prescribed controlled medications, whether they're paid for by cash or by plans, and it's been challenging for people to use. There's a new CURES 0.20 platform that's going to be rolled out in late summer, early fall, that will allow a prescriber to log in and then actually get a report of all of their patients who hit a certain threshold of risk, whether it's co-prescribing of benzos and opioids or all of them adding up to a certain morphine equivalent dose. So that's going to be a great resource later. I have another question that came in about how did you do your messaging? Were you trying to reach prescribers through broad messaging, trying to hit everybody, or were you specifically targeting the high-use prescribers? And then do you have some references for the hyperalgesia, because that's a little bit controversial?
Yeah, so for the
go ahead.
Yeah, so for the first part is we really, as we were fortunate for both the Multnomah County perspective, but also in Jackson as well, where we had such significant partnership, you know, with public health. So we were able to really come up with what would a communication plan be that would be both at a community level as well as the individual provider level. And then on the coast, what we did was, it was really interesting as a plan, we held community forums and dinners. And, you know, and most of it was targeted towards the medical community, but certainly was open to a lot of the community members that were there that had an interest around chronic pain, and that's when we started all that messaging that was there. And then for the references on the hyperalgesia, we can get that to whomever needs it.
Yeah, and this is Bob, and actually if you go to Partnerships website and go to Managing Pain Safely, we have a little provider toolkit that has the references embedded in that. And the two methods were, one is, you know, whatever method you communicate with your medical community, and obviously as a plan, it's tricky to get to the entire medical community. So that's a separate, really important function for a high-functioning, you know, health plan, is to figure out how does it actually engage its frontline providers. The way that we've done it is focusing on the clinical leadership, really engaging them, getting to know them personally, and then on an occasional basis asking them to forward to their providers by electronic means. Email is the best way to do it nowadays. You know, particular targeted messages. So that's, and then in terms of attaching associated sort of analysis or white papers is helpful too, because you can't, in a short message, you can't present all the data behind a particular you know, argument, and so that's the place for either a longer blog article or a sort of a white paper or some other way to reference other materials. So we incorporated them into our recommendations, and you'll see on our website if you go there, we have 4 sets of recommendations for primary care specialists, for emergency room, for dentists, and for pharmacies, sort of best practices.
Great. And just so you know, if you have trouble finding the chat button, it's a blue button in the upper right. There's lots of good questions coming in. One question has to do with the pain specialists, often the interventional ones. Did you specifically have to work with the pain specialists who are often part of the problem in terms of prescribing very high-dose opioids themselves? And then how did you deal with the overuse of injections, which, you know, these, especially for chronic and back and neck pain?
Yeah.
So
you go first.
You know, there was, yeah, that is a great question, and it was a big issue in one of our service areas where we found the highest prescribers were actually the folks that were in these pain specialty clinics. And, you know, when you dug a little deeper, you found the root cause analysis was it was a way in that community for primary care to not have to manage it, right? They would just be like, well, yeah, just go see the pain specialist. And so we had to do a lot of direct work with them and spend a lot of time. And it was, and from our experience, it was quite, you know, I don't think shocking or surprising. There was just as much need for education around the management of opiates with them as there would be with primary care for a variety of different reasons, but a similar end game of, you know, being with a large group of people with large doses of opiates, and quite frankly, the pain people not knowing what to do with them either, right, and not having the behavioral health supports and all those pieces that are in there. Regarding the interventions, you know, in Oregon, because of the Oregon Health Plan and the benefit around Medicaid as an example, you know, there is a large movement that's happening, and it's going to be piloted starting in a few months, where we're changing the benefit from saying that the benefit will include all these non-medication management strategies that were previously not part of the benefit, and opiates are not part of the benefit. And so what that's moving towards is getting to your question is the interventions for stuff are going to starting to become not part of the benefit structure. And then doing all the things that we articulated and Dr. Moore talked about in his presentation, doing all those things will start becoming the way the benefit is covered for the management of chronic pain, with opiates and interventions being way far down the path, as opposed to being the place you start with first.
And that's a good summary. And we had similar experience. So one of the things that's happened in our region in the last few years, and I'm not positive of all the reasons, I suspect it has to do with a greater scrutiny from regulatory bodies and just being overwhelmed by the sheer number. So as the number of individuals that are on high-dose opioids has skyrocketed, and then the official guidelines on a lot of primary care, websites will say, be sure to send these folks to your local pain specialist, kind of cover you. And so the pain specialists were getting overwhelmed with patients on high doses not being really well managed or well controlled. And so in our region, the vast majority of pain specialists said, we don't do long-term opioids. That's your problem, primary care. You started them, you got to take care of them. We have a few exceptions to that, but mainly they do interventions now. So that's been, and that's actually in a way helped, because then it reinforces that you can't just start the patients and push them on. One thing to keep in mind, those few that do opioids, there is an educational issue, and part of it is it's a little harder in some sense to change the attitudes and behaviors of pain specialists. And not to go into too much detail or too much politics, but there was a concerted and not transparent marketing effort by a number of pharmaceutical companies that led to a big part of this opioid overuse. And I think that's still going on to some extent. And so that's one reason that some folks are resistant to sort of, to the ideas that, ever high doses. I still hear some pain specialists who say that really the evidence for high doses is pretty good, and increasing them whenever a patient complains is pretty good. And I think that's a residual effect of that marketing campaign. And it's always hard to change your view when you've had a long-held belief for a long time to change that. But anyway, that's part of what's going on. In terms of controlling the interventions, about 6 years ago or so, we implemented a prior authorizations criteria that's pretty rigid in terms of for injection therapies, and to really focus on the folks for whom there's evidence of benefit. The worry, it's not so much that if you have a good evidence of benefit, in some cases you can help patients get off of opioids, and that's good. But in some cases they were being overused because they're a quick source of high income, and so by doing that we able to hone in on the folks who really need the injections the most.
So great. Just we are at the end of the formal webinar, but we're going to keep everything open for questions for the next half hour. We still have a lot of people on the call, so we're going to continue to mute you and use chat until we're down to about 30 participants. Otherwise, it's too hard to manage voices, and I'm going to continue to tee up questions. You will see a survey on the right, or in the upper right corner, you see polling. We'd love your feedback. If you could click on that and answer just a couple of questions for us, it'd be very helpful. So Bob, this is specifically for you because it's focused in California. For things like acupuncture and chiropractic, and then specifically about lidocaine patches, which tend to be used off-label a lot, what is your policy? Do you allow those for a focused population or for everybody?
That's a good question. So the chiropractor and acupuncture benefits were removed in 2009 during our state budget crisis, and they were never re-added. So partnership is using some of its reserve money to provide that as an enhanced benefit. The state won't reimburse us for that. And we're focusing in, as a result of that, it's not for everything. We're really focusing in on using that as an adjunctive treatment for this population of folks on chronic pain or at risk of being put on chronic opioids. So pretty focused benefit. And in terms of the lidocaine patches, it's pretty narrow, mainly because it's an expensive modality. It's really there's not good evidence that long-term provision of lidocaine patches outside of a couple of indications is an effective method, but we do cover that for certain indications. And obviously, all of us in health plans, we have a prior authorization process, and in some cases, you can't put everything into criteria, so we look at things on a case-by-case basis.
Great, and so once again, I want to let you remind you that the partnership website, Managing Pain Safely, has a wealth of resources, toolkits, guidelines, references, so we do encourage you to check that out. There was a question that was asked about, can you obtain cures reports for all providers within a practice? If not, how do you track individual prescriber patterns outside the EHR system? And I'm actually going to answer that one since I've been working with Mike Small, who's the director of Cures, and he's been asked that many, many times, and it's very specific that health plans cannot look up cures, that according to the legislation right now, it's only for providers on the care team. And certainly, there's some health plans that have tried to find a little wiggle room in that, and so there's not a great way for health plans right now to know the prescribing patterns that are paid outside that health plan. I think that all of us who've been in health plans would say there's plenty of work to do within the patients that you have the data for. So even though you're missing some, there's certainly a lot of patients that you'll be able to impact. Okay, so one question I would ask both of you to address, maybe first Bob and then Amit, how do you make sure that providers don't go to the other extreme, saying basically we're not going to prescribe opioids at all. We're going to fire all of our patients who've shown the signs of addiction or tolerance. Can you address how you're helping them strike that middle balance and not overreact?
And that's a great question, Kelly, and it has happened. We've had a few providers who either they get scared by something, and I don't think that health plan is precipitating it necessarily, because my suspicion is it's more worry about the DEA or the medical board kind of coming down on them hard. They may have a colleague that's gotten in trouble and they don't want to get in trouble. When we've been made aware of that, we try to have our providers, our regional medical directors reach out to those prescribers and just to remind them that it's part of your ethical responsibility as a primary care provider to provide this. This falls within the realm of primary care, and if you want support, we'll be happy to provide support. We can talk about that, especially make sure they get a good referral to mental health, the other modalities are available, some coaching on how to handle them. But a lot of times it's just they don't have the training or skills, and it's not, you don't have to go back and do a surgical residency to learn how to care for this population. The knowledge is obtainable, and so that we try to provide that support where we can.
Yeah, and just adding on that, it's a similar thing. It's that it's been my experience and our experience that it's the need for technical assistance on this is great, because the tool that people have had in primary care as an example to manage chronic pain has been the opiate, right? And then to manage the patient beyond the opiate and to deal with all that stuff, it just gets really difficult. So the easiest thing to do is just say, oh yeah, I don't see chronic pain, when the real issue is that you should be determining whether it's appropriate for opiates or not, and if it's not appropriate, that doesn't mean you don't treat the chronic pain, right? And then what are the tools that are needed to treat that? And that just discussion in and of itself and going through that with providers is really important for that to change the way that they practice. But, people know that when they take chronic pain off of their panel, as Dr. Moore alluded to in his slide presentation, a lot of work disappears. So sometimes it's natural for people to do that, but it's to help them understand the bigger picture and sort of where that patient is best, care is best, which is, really, from my perspective, in primary care.
So Bob, you focused a lot on helping providers taper, and I know you've got a great Kaiser resource. Could you summarize a little bit about the tapering approach? Are you trying to get people down or off within a month or two? Are you using a long-term strategy? What have you found works best?
Sure. Well, we definitely give tools. In the end, if you think about it, only the prescribing clinician can actually do the prescribing needed for a taper. It's something that we can't, we have to encourage them to learn how to do it and decide if it's going to be a slow taper or a quick taper, if it's someone who's not the right candidate. So we've developed a list of sort of what are the instances when you would not taper, and made a real conscious decision to identify those individuals. And we ask if they have any of those conditions, and sometimes we ask for documentation of that, so it's not just sort of an excuse. And then try to provide some additional resources for how to do that. There's different methods of doing it. They range from sort of the correctional institutions approach, which is you just stop it. There's the VA approach, which is you cut it in half, and then you cut it in half the next day, and you cut it in half, and then you stop it. So it's like a 3-day taper. So that's the one extreme. The other extreme could be the Kaiser sort of very patient-centered approach, which is they encourage them to taper, but they wait until the patient thinks that they want to do it, but they won't escalate it, but they keep talking to them about the benefits of it, and they kind of get the patient's buy-in, and then they'll do a taper. And then there's some other nuances. If a patient is diverting medication, you can taper them pretty quickly, and they won't have any withdrawals, right? So you have to kind of decide if it's a potential diversion, then doing a quick taper is a good way to kind of get a sense of that. You taper until you start to get withdrawal symptoms, and then you go slower. So if you don't think that there's diversion going on, then you can still usually cut down it first quicker and then slow it down after that. Some populations are not safe for tapering. A good example is pregnancy. So you have to kind of screen for all those conditions that are not appropriate for tapering as well.
And I want to give everybody a heads up, if you want to save the date, September 28th and 29th, we're going to bring Dr. Corey Waller for an intense workshop on how he's a pain specialist and addiction specialist, and he works with people who've hit the ED at least 10 times a year for 2 years in a row, really tough populations, and he's just a very inspiring speaker and great to learn from, especially about how the neurochemistry changes with long-term opioid use. And his advocacy is to do slower patient-centered tapers to avoid people being driven to the street or to heroin. So September 28th and 29th, we'll be getting information about that soon. I just wanted to let you know. So Amit and Bob, can you talk specifically about those new to opioids? Like maybe Bob, starting with operationalizing this in a large plan, how do you know who's new to opioids, and how do you get to them before the 90-day cliff? What are you actually doing?
Well, we haven't started yet, but here's our plan for later on this year. We're still stabilizing from our basically encouraging consideration of tapering stage. The plan is to be able to run reports. Fortunately, we do get prescription drug data on a monthly basis. So if we run a report and we find that someone has been started on opioids and then they've been on it for our thought is to wait until they've been on it for 2 months and then have a very rapid response to that, where we reach out to the providers, the prescriber, with our medical director staff and talk to them and just say, are you really sure this person needs it, because you're getting towards that cliff of not being able to get them off. So that's our plan. I don't know how that's going to work out, and I'd be curious if Dr. Shah has any experience with that approach.
Yeah, and that's very similar to sort of what we're doing, and what we're entertaining is so the first part is, yes, that's very consistent of how we would look for it through our data. The second thing is that working tightly with the clinics, because they're the ones that know the new start and the education that's needed around it. Like, people don't know about things like 90-day cliffs and so forth. And the third is something that we've played around with, but we don't know, and we're going to ask our community and our network and our partners what they really think about this, is there is more movement happening in Oregon around, we talked about the 120 MED PA, but there's talk about just opiates as a PA in general. So obviously getting opiates acutely would be defined by a period of time, and there's no PA required. But after a certain time, regardless, that would require, regardless of what the dose is. So that's going to be an interesting, piece there, that, you know, acutely, emergency, something like that happens, that's one thing. But then if somebody chooses after, as Dr. Moore suggests, after it's, you know, 2 months, or is it 6 weeks, or is it whatever the time frame is, that, you know, that benefit just wouldn't happen. You know, and from a plan perspective, it would be like, you know, there needs to be a prior authorization to say why you need it to be longer. But we'll see how that turns out and if that really gains traction. But I believe that the new patient education belongs, and really the plan can help with this in the clinic to really have them understand, you know, what it means to start somebody and what the ramifications of that is.
Mm-hmm. Yeah, I think that the education is critical. We tried to think of a way to do that, the prior authorization mechanism for new opioids, but we couldn't figure out how to program that. So if you figure out how to program it, I'll be really curious to know. We couldn't figure out how to make, the system stop the continued dose.
Yeah, it'll be interesting to see if that's the direction that things go in.
So great. I'm going to now open up the line. So if you can, if you aren't going to speak, if you could mute your phone, and please don't put us on hold. We've all experienced hold music. But I'm going to open up the lines for any other questions that you want to ask directly. So I'll tee up one question while people are thinking of others. You spent some time talking about PCP support, and I wonder if you can go in a little more detail. Certainly what we've heard with PCPs is they're already overwhelmed with the amount of work that is on their plates, and even though certainly life gets easier after patients are on buprenorphine or been transitioned down, that activation energy it takes to be able to take a panel of patients and work with them individually to taper them down is really tough. So can you talk a little bit about what your approach was?
Yeah, I mean, from the plan perspective, you know, we really built upon a lot of the work and stuff that I did previously in the organization in Multnomah County, as well as a few other FQHCs where we've piloted this work in. But really, what it came down to was a few things. One, being able to meet with the provider and or their clinic and really sit down and have them understand what we're really talking about and what we are seeing with the data and the information. I think that's a big piece of it, because I think it's surprising, not surprising that a lot of primary care providers just don't even have the time to even grasp that there's something going on and what does that really mean, because they're really doing a lot of individual care and not really looking at the population care. So I think there's a lot of that piece. Then it rapidly goes towards, depending on what patient population segmentation, as Dr. Moore illustrated, you know, where is their burden? Is their burden around chronic opiate patients that they prescribed for the past 10 years? That's a different management strategy than I joined this practice and now I've inherited 400 people. You know, so the strategy around the population segmentation and understanding the interventions that are needed. And then spending a lot of time with the providers around literally technical assistance around how do you taper? How do you have a conversation with the patient on this? How do you, you know, manage other concomitant high-risk medications? How do you link the patient to resources that you don't have in your clinic that's going to be needed to do this? And a lot of time spent on that, with a cornerstone being behavioral health. Whether they have, if they have it, that's great. If they don't have it, finding a way to provide them linkage with that as soon as possible.
Great. And Jeff Robertson, you had a question? You want to chime in?
Yes, I did. Probably as much for Bob more than the others. But in California, as we know, all of our best made plans can be scuttled by advocate groups who oppose our well-intended plans. You know, this kind of being, I assume that's part of what this call is about, is to enlist collaboration. But how do we get our regulating bodies to support us in doing what some individuals or advocates might view as bad for them individually?
Yeah, that's a great question. I think, we've tried to engage the state, so that's one of our big regulatory, and I don't worry as much about auditors' engagement because we just see them when we see them, but at least our contacts at Department of Healthcare Services to really help understand what are, and I think all the medical directors are involved in this to help understand what are the big issues that we're involved with. And And I think this issue, and Kelly will know this, I think it made it into the discussions about the state, the DHCS quality improvement plan. I think that the opioid overuse did make it there. So that means that they're aware that this is a major issue. The other thing that's happening is the Public Health Department, Ron Chapman started this before he left, is really starting to focus on this as a public health issue, which I think will help a lot.
And the Public Health Department launched an opioid misuse and overdose prevention work group, which is really unprecedented. I haven't seen it in California before, where they've got the Department of Justice, Department of Managed Healthcare, DHCS, Medical Board, Pharmacy Board, Public Health, a whole variety of state agencies that often don't talk to each other, and they sit in the room once a month together trying to problem solve around this issue. So I think we may have more support from the state than in the past, and specifically Neil Kohatsu, the Office of Medical Director for Department of Healthcare Services, is very passionate about the issue and has prioritized work on it. So if anyone has any specific ways that they are having challenges with the state in terms of pushback around this, certainly the California Healthcare Foundation would be interested, since often a role we play is working with the state on how to solve these problems at the statewide level, so every plan doesn't have to figure it out for themselves.
Yeah, and just two thoughts on that, Kelly. First is I was intrigued that Oregon eventually is now working on a multi-payer solution. I think that'd be a great something for us to think about in California, moving towards that. I think that we're probably ripe for that in the next year or two. And then in terms of the other part about the advocates, if we can get the prescribers to make the changes instead of us, then really there's not much in the way of appeals that happen. So the goal is to actually put pressure on the prescribers, not on the patients.
And if I could put on my old CMO hat, when I was a CMO in a different county, one of the biggest successes is we put out a set of guidelines, and then the public health system took those guidelines on as their own practice. So certainly, just echoing what Bob said, is when it's coming from the providers themselves, it has a lot more credibility than when it's pushed out from the plan. But certainly the plan can often be the catalyst, the instigator, and to push it, but then hopefully in collaboration with the providers, so it becomes a group effort. What other questions do people have? Just jump in.
This is Bob. Just in terms of, medical directors who haven't gone this route might be worried about lots of appeals and so on. And our appeals and grievances department was very concerned about that. But because we laid down this groundwork in terms of getting everyone on board with what the messaging was internally, and we really worked very hard with educating the provider network externally, the number of appeals that came in as a result of the formulary changes we did was very minimal, considering how many patients that we have.
Can you hear me?
This is Grace from Valley Health Plan, and I was just wondering, has your data been published? And if it hasn't, is it something you would share your methodology and data?
So this is Bob. In terms of the decreased opioid use, it's still coming in every month. It's our monthly data. We haven't published it yet. And in terms of the death, the overdose death, that takes the state about a year to 2 years to validate and publish the final statistics. So what that is, that's preliminary data. I won't even say what counties it's from so they don't get in trouble, but that's preliminary data. That's a big problem, though. The most rapid data we have is actually the prescriptions themselves. The side effects, like neonatal abstinence syndrome and deaths from overdoses, the data flows very slowly for those. So you'll notice the benefit of that much farther out down the road. We have a data committee that's focusing on it. It's even just getting data on how many patients do you have that have over 120 milligrams morphine equivalents a day total dose. The calculation for that is rather complex, and then to ask of those how many of them are escalating, another huge complexity. So we have a number of analysts that are working on just such simple things as that. So the data needs are complicated.
Thank you.
Other questions or thoughts?
And then just to follow up in terms of the methodology, if someone wanted to know, what are all the different fields, we have the specifications for instance, for other health plans of, how do you take the raw, it's pretty intuitive. You have to come up with a morphine equivalent dose for every type of opioid, and then you have to multiply it out and then add it up by all the patients. So giving you those specs won't help reduce the amount of work it'll take to program it probably.
Okay, thank you.
Other questions or comments? So I'll jump in, Bob. I'm curious about this concept of a multi-payer solution or multi-payer collaborative. Do you or other people on the line have some thoughts about what that would focus on?
I'd love to.
Would that be?
I'd love to see what Dr. Shah. Go ahead.
Yeah, go ahead, Bob. Well, I'll just say that one of the things that I've thought about, it looks like in Washington there was a big effort to have the pharmacy lock program be spread across Washington, meaning that if someone was identified as a high-risk user going to multiple pharmacies and multiple providers, that there's a process in place where the health plan could only approve opioids if prescribed by one provider, one provider group, one pharmacy, with some obvious exceptions for emergency prescriptions. And that seemed to be a big piece of what drove down some of their ED visits, and so a lot of people were using ED for opioids. That's one thing I'm thinking about as potential multi-payer to get all the plans on board about doing something similar. But Emma, what do you think about getting all the payers together? What would be a good starting place to work on together?
Yeah, I mean, I think one of the starting places that we are doing, when I alluded to in the earlier part of my presentation, was really bringing the payers together and saying, first of all, getting in a room and understanding what everyone is doing around this, if they are doing anything, because most people are. And then where is the synergy around where we could do? And one of the first couple areas or few areas that people feel a lot of synergy here on is getting people to have relatively common standards and guidelines. So you say 120, I say 180. You say 180, I say 60. And trying to keep very consistent standards around that. And could we agree upon some very consistent things? And that was a document that we produced from a multi-stakeholder, multi-payer as well, but multi-stakeholder document that included, like, I don't even know, it's like 16 or 15 things that everyone could agree to. So the first is just trying to get to some agreement around guidelines and standards and what to use. The second is, really moving in this space of like, well, then what could you do together? And Kelly, using your example as one is like, could you do something where all the payers agree that in certain situations they would do that sort of action? And we really are at just the beginning of that piece, around really trying to design that and getting folks together. In Oregon, we do have a forum, though, where all the multi-payers get together. And so we've been using that forum, which has two arms to it, the leadership of the plan, but then it also importantly has the clinical leaders meet together, and that's been a really good forum to have this discussion.
And this is Bob. How much time would you say would be a good time chunk to if you get all the clinical leaders in the room and your goal is to come up with some some agreed upon standards that they would probably all take back to their advisory committees and so on? Is that a 1.5-hour meeting, a 2-hour meeting? What do you think?
Yeah, it was interesting because we had to cram it because that meeting was only meets for an hour and a half, and they have like an agenda that's 5 million things. So it had to be a series of meetings to really get there. But then there was enough, after the first couple of meetings with a couple inspiring speakers, there was a lot of momentum to people saying we've got to make this a priority, and getting people to really commit. And, we have some things like in Portland where we tried to throw out, could we all agree to January 1st, 2016 to be when we all do this? Right, trying to throw dates out to get people to do it. So it's going to be interesting to see because people have agreed to a lot of things, but when it comes to that, to sort of operationalizing it, it's going to be very interesting to see what people do. But I think it takes time.
Yeah. Seems like Kaplan might be a good location just to get both the commercial and the non-commercial, but also more importantly, not just the Medi-Cal population, but the total population.
It's a great idea. I know there's some plans who are still on the line. If any of you want to chime in about where you think a good place to start would be. I think we'll close. We're just a couple of minutes short of 2 o'clock. If any of you have any additional questions, comments, thoughts about future directions for ways that California Healthcare Foundation could help move this forward, or ways that, say, Bob Moore and his leadership role with other medical directors could move forward in terms of having plans to collaborate on this very tough issue, we'd be very interested in hearing from you. I want to once again thank Bob Moore and Amit Shah. We learned so much from your experience and your honesty about what's tough and what successes you've had and where you're still working on it. So thanks again. As a reminder, we have one more webinar in this series that's scheduled June 4th, and that's going to be focused on teaching safe practices to primary care residents, looking both at the infrastructure of a clinic and curriculum. And as I mentioned, we now have 8, potentially 9 participants in our action group all across the state, residencies working on how to implement safe prescribing in their programs. We may do additional webinars, so if you have other topics that you would like to hear from, one topic that was teed up is how clinics are using multiple modalities to treat pain, apart from opioids, and how clinics are managing given current payment structures. That's one we're thinking about. But in any case, my email is kpfeifer, kpfeifer@chcf.org, and we look forward to your feedback. Thanks again, and have a good afternoon.
Thank you.